Good afternoon, everyone. This is our final session, and we start out with our second keynote address of the workshop. We will do our very best to get you out on time, and we will go straight through from this address to the closing panel. So the closing panelists, be prepared to get up here, zip up here, as we would say in the States, as soon as we're finished. We are very fortunate to have Nduku Kilonzo, I hope that wasn't too terrible in pronunciation, it was okay, as our final keynote address. And by way of introduction, as of May 2014, Dr. Kilonzo is the director of the Kenya National AIDS Control Council. Before assuming this position, Dr. Kilonzo has been involved in the development of innovative, quality-assured HIV testing and counseling programs in Kenya, Malawi, Botswana, and Cote d'Ivoire. Most recently, she was executive director of LVCT Health, a local Kenyan NGO offering care and treatment to over 40,000 individuals, testing to 1.2 million annually, doing research and policy reforms. Her primary research and publications have been in the area of sexual violence and HIV. Her work has provided evidence for the development of integrated public health facility post-rape care services that are currently offered in over 250 hospitals in Kenya and HIV prevention interventions. She is widely recognized for her research expertise, innovative program development, and policy work in the area of HIV and intimate partner violence. And I would just like to say, I know she's not feeling terribly well, and we're incredibly grateful that she was willing to go ahead and give this address this afternoon.
Good afternoon, ladies and gentlemen. Okay, you can hear me, I guess. I'm going to be a little soft on my voice, and I'm going to speak from two perspectives. I'm going to speak from the perspective of being a researcher, understanding the question around the questions that we need to be asking, understanding the issues around being a programmer and what we need for programming. And also, more specifically, I'm going to talk about how we translate everything that we have been talking to into policy, and perhaps where the gaps have been, perhaps where the challenges are, and what we need to think about doing differently, what questions we need to start answering if we are actually going to make a difference, and if we are going to translate all this evidence we have into scale, at least from a policy perspective. I want to start by talking about the story of Jane. Some of you may already have seen a few of these slides, but I'm just looking at that data. And when you look at that data from those 4 countries, which was the Violence Against Children studies, which are population-based studies, you notice that on average, 1 in every 3 girls in those countries is raped by the time she's 18. I want us to take a pause for a moment and think about what that means in our countries, because these are population-based studies. We don't talk about them, we are not sharing this data. And 1 in every 6 boys, on average, is raped by the time they're 18. And this has implications for many things. Of course, I cannot get away with what the implications are for HIV. You notice that young men who've been raped and women who've been raped are 3 to 4 times more likely, in all cases, to have more than 2 sexual partners, to have undiagnosed or symptomatic sexually transmitted infections by the time they are 24, and to have infrequent or no condom use. So, assuming that Jen is one of the girls that we talked about, because sometimes we talk about a statistic. I want to put a name to the statistic. Jen, not her real name, is now 16 years old. And this was an interview I did many years ago, and I think I've shown this slide so many times because it has resonance for me in many different ways. In this case, as a 16-year-old, did Jen consent for sex? Was Jen coerced, or was Jen raped? So as we start to think about the transition or movement and Jen becoming either a victim of sexual violence and perhaps tomorrow having a perpetrator, we need to start to think about the context where Jen is coming from. And in this case, what is the power of bargaining? If she cannot bargain when she's 16 years old, is she going to be bargaining when she's 25 years old and in an intimate relationship? So just Jen's likely future, when you think about it. And Jen is 1 in every 3 girls. Remember the data we just started looking at. Jen's likely future, if you look at data, although we don't have longitudinal data on partner sexual violence, on non-partner sexual violence, we have increasingly more data, and I'm sure it has been shared by many people in this room in many different ways. And clearly, there are certain issues. We have the psychosocial issues, we have the violence, physical violence issues, but we also have the issues around other HIV, STI transmission, and other diseases. But this goes beyond just health, or rather HIV as a health issue. It goes to maternal health, it goes to reproductive health, it goes to child mortality and maternal mortality and morbidities. And all those figures add up because this is Jen's likely future. And so perhaps maybe the question is, when we step back, are we surprised at what we have for our maternal mortalities in our countries? This is DHS data because eventually at some point after the VAC studies, Jen will be part of a DHS sample. When she's part of a DHS sample, this is the data. She's a statistic, yes, but this is what it is going to look like with physical and sexual abuse, and be in a situation where she has negative outcomes for productivity, for sexual and reproductive health, number of visits to facilities for HIV. So whichever way you look at it, until we start to get down to the question of violence in general, whether it is intimate partner violence or it is gender violence or sexual violence with non-intimate partners, will continue to be in this cycle, because to me it looks like a vicious cycle. So what lessons do we need to learn? Because it's all not a grim picture, and there's a lot of people in this room who've done a lot of work. While we know the statistics are there, while we know that is a story of Jen, we also do know that there's something that we can learn. Let me start by just talking a little bit about, when we talk about intimate partner violence, the yellows, I put them in yellow because often survivors will not go to the health or the police. So those are very good pathways that we have thought about when we sit in a room and design interventions. These are the pathways that we design. You go to the healthcare, you'll get counseling, you'll get psychosocial support, you'll be referred to some other program, and then finally the evidence will be delivered to the justice system. But let's think about the family, which is the box there that is in lines, and potential ostracization that Jen has to face. Is she going to go really to a facility? Let's think about the community and the social norms, and then these systems are not going to be friendly, or are not always friendly to Jen. So what do we in this room need to do differently and to work with these systems? Let me just reflect a bit, because legislation and legislative response is really a key part of what we do with intimate partner violence. Now, whether that legislation is going to be formal legislation, or we are going to be looking at community systems, because we do know that there are places where community systems have been used. The question is, do they work? What do we know about them? How much do they actually entrench the gender stereotypes we have? We really don't know how much. But having said that, we know that we draw differently from the international laws, from regional conventions, agreements, and covenants. But importantly, there is no consensus on the exact elements constituting offenses related to gender violence, and I will say that because I'm talking about sexual violence, intimate partner violence, all these forms of violence, we do not have any sort of agreed on, and we also do not have age distinctions in their definitions. So I use the word child always comes to mind. We are not sure who is a child in Kenya the same in Uganda, and even if they are a child in Kenya, are they allowed to be married by the time they are 14, although their universal coverage, suffrage age is 18? Those are things that impact a lot whenever we start to think, because which 15-year-old is going to be married, whether she's married off or she chooses to run away with a man, is going to be able to negotiate for sex, is going to be able to negotiate for condoms, is going to be able to protect herself. So these have implications. But I want to talk about the lessons, some of the lessons. I started by saying that I will not necessarily talk about exactly the data. I'll use that data to ask ourselves some hard questions as researchers and things that I think, excuse me, things that I think we need to think about. The first one is positioning and leveraging. In every system, in every economy, in every country, the economy and politics and government are interrelated, intertwined. They will work in ways for the good, for the bad, but that's just how sort of our governance works. So if we want to make this intimate partner violence, prevention and response, an issue enough to get the response that we are looking for, we must start to speak to the politicians, or rather to the things that are important for politicians, not necessarily to them, the priorities of politicians. We must start to answer economic questions, and we must start to be able to ensure that sectors have targets. And I've written a coordination mandate twice there, because the reality is this: like any major system, a government has systems. And for it to be able to take on an issue, the one question will be, who is responsible? Second question will be, how much money do you need? Third question is, what targets will be met? If we can't answer those questions, it's highly unlikely, regardless of how much data we have, we are going to get people or the government interested. And so if we don't have a mandate of who coordinates, because this is a multi-sectoral response, it looks beyond just sexual violence in the health sector. You have somehow the legal sector has to be involved. If you want data from legislation or data even from social services that speaks to the health sector, the health sector is not going to run an IPV program and social services walk in. They will say, we have our own IPV program, because they have a responsibility. So who is the coordinating authority? And in many countries, we have gender commissions. It's time to start to think about that, because if we don't have an anchor, it's highly unlikely we're going to push it somewhere. Somebody has to be willing to take it up. Second thing is, beyond the health sector, we must talk to the social movements, to the trade unions. Have we made IPV a trade unions issue by being able to provide trade unions the impact of IPV on the bottom lines of the key sectors? So in Kenya, horticulture is a key sector. We also know that's where there's huge incidences of IPV. And I'm sure in the countries we can also have something like that. Can we start looking at modeling or data that then starts to speak to that? Because then you get the trade union interested, because it speaks to their bottom line. The evidence. The other question is, what needs to be done? Translating research from policy to practice. Research translation to policy and practice. I think often when we think about research, we need to be thinking about how much we can invest. And currently, IPV is not an area with sufficient resources for us to do all the studies that we would like to do. And there are many other areas that do have sufficient resources, or rather more resources. I'm not sure sufficient is ever possible anywhere, but more resources. Are we getting HIV or are we getting IPV questions into HIV programs? If we are saying that the current issue, biggest issue right now, and that is going to continue to receive funding if nothing else does, is treatment, at what point are we doing treatment studies and looking at the impact of IPV on treatment? Because that will get people listening. Because treatment, we all have to achieve viral suppression. So if IPV is the reason we are not doing that, we will have a conversation. But we have to have that data. So all the data that's going into treatment, if we're looking at maternal health in our countries, are we looking at the reasons why women are not going for the 4 antenatal visits? And are we looking at IPV as an issue? And in those studies that are ongoing, asking the designing relevant questions. Because if we are not doing that, then we will not get the data that will get everyone going like, oh, wait, stop. The only way to change this thing around is deal with IPV. So I think that's one of the areas. I think the other areas is negotiation with statisticians is required. For many of our countries, population-based surveys are done through the national statistics bureaus in their different names, isn't it? Who has ever tried to go and sit and negotiate for indicators? Who has ever tried? I saw a hand or two up. How easy is it? It's impossible, right? Okay, because at the end of the day, there are several questions to those negotiations. And one of them is about how much is this going to add in terms of cost to an already expensive model. But importantly, how much is it going to answer the bigger question of national priorities? So if your national priorities are infrastructure or maternal health in health or retention to secondary school, our IPV questions need to speak to those things because Central Bureau of Statistics is interested in national priorities because everyone goes to them with their own priorities. So their focus, national priorities. Can we design indicators and questions? And can we train the people doing IPV studies so that they're able to negotiate with statisticians in that language where they're able to actually say, this is why it is important, this is what the data will tell us, this is what it will give us, this is how we'll cross-tabulate it with some of the questions you have asked to be able to answer this national question. And we need to develop interventions that can be brought to scale. One of the things that happens, and I think we were just having a lunchtime discussion, is we have very good studies, and they show us what works. But if we are going to bring anything to scale, it's not about what works. It's about identifying the elements of what works, because scale is about compromising some things. If you're going to bring it up to 20 million people or 10 million people, you must be able to say, of all the things that we are willing to give up in this intervention, these are the core elements that cannot be negotiated, must be delivered in the same way. Because when you bring to scale, you're talking about many different providers, you're talking about quality assurance and control changing, you're talking about being able to reach many different people, you're talking about who is giving the information, you're talking about where the information is given, things that actually kind of remove themselves from the fidelity of a trial setting. So I think often when we are doing trials, we don't kind of say, okay, what's the next step? Sort of, what's the next step? Do we have sort of any data? Can we design some implementation studies that will allow us then to determine these are the elements that must be kept for this to be successful, and these would like to keep, but if they go away because something will give, then it has to be this. Because then that allows whoever is designing programs to know what cannot be negotiated and what can be negotiated. Because currently, from RCT to scale, half the time, everybody negotiates what they think is the easiest to negotiate without being clear what it is that cannot be negotiated. So what evidence should we be generating? I just tried to kind of come up with a few immediate thoughts. When I think about political, I think about post-2015, I think about the current gear on EMTCT and any maternal health. First thing I would ask myself is, what's the impact of IPV on maternal and child mortality and morbidity? Because right there, if that is the one thing that is stopping us from the goal, we are going to address it. Because this is a political goal. Everyone has accelerated themselves around it. The UN General Assembly is going to be looking at maternal health as a goal. It's a key factor for 2015. This is it. So and that's what I mean, that the data we provide, and it can either be done from modeling, or it can be done from studies, or it can even be done from program data and reviewing of program data. Economic. Every country wants to know what is the return on investment on the key sectors that drive my economy. Half the time we don't have that data. Half the time we don't think or we don't speak to those sectors. But when we think about them, IPV has a direct impact on those sectors. I can't pretend I would know how to design such a study, but at least I know the questions we need to be asking. I'm sure someone in this room has some clever ideas about how we can do that. And then, once you've done that, you also have to answer the question, what is the cost effectiveness? Because if the cost of your intervention is so high compared to the cost of other interventions that will give me a higher return in agriculture and infrastructure, we'll just have to live with it. It's an economic decision. So it's also about saying what's the cost effectiveness, and it goes back to saying what is it that we can give out and what is it that we can't compromise in any intervention, because that will determine the cost and the cost effectiveness at scale or of scale up. Technical, what's the cost of preventing IPV? Rather than just saying what's the cost of IPV, what's the cost of preventing IPV? I was just giving an example. What's the unit cost of delivering interventions? So the other day, I think when I was introduced, I'm sort of new onto the national job, and the first thing I had to do, because we were coming to the end of the financial year, was get into the budget negotiation phase, because then we had to negotiate our budget July onwards. So in May, June, all we were doing was budget negotiations. And, you know, we went there, we had managed to agree that IPV is a priority. And when we went to negotiations, I said, okay, fine, no problem, whatever your priorities are, these are the economists and the planners from planning and treasury, okay? They're not interested in all our things that we consider important. They ask, what is the cost of the intervention? What is required of the intervention? You don't have costs. We can't budget for anything without costs, so just take it out, you go and sort out the cost and then come back next year. So much as it is an important issue, I understood what they were saying. They're national planners. They have 50,000 other things that are priorities for the whole country. If you cannot defend the cost that it will take, then it can't make it to the budget. And if you defend the cost, then there are also the other political issues that come in. But at least that's the first step of making that happen. There's advocacy required and all of that. But if you don't have that, advocacy will take you nowhere. So I think these are some of the things for me that are very important. What's a unit cost of an intervention of within existing programs? Because I think that is perhaps even the fastest, the easiest. Existing programs, existing reproductive health programs, what packages can be scaled up rapidly, and what will be the return, and what will be the targets. Because on the other hand, if you have an intervention that reaches only a small group of people, however effective it is, at country level, the decision will be like, we need something that can reach way more people. So, lesson number 2, a common agenda. So the common agenda and the common goal is we need a common goal, whether it's IPV reduction, IPV health services, IPV reporting. If we don't have a common goal, common targets, what happens? And I know that many of us don't like thinking about targets, but the reality is if we don't have a common thing that draws everybody around a table, it is highly unlikely that you will get government commitments. Government want to see something they're working towards. And something that at the end of the day, they say, we did this. So of where we said we were going to go, this is how far we got. So I think it's really important to start to coalesce ourselves around a common goal. Common understanding and measures. I don't think I have to speak about that. I'm sure it might have been talked about a bit somewhere during this meeting. Standards. We say we have behavioral interventions, we say we have structural interventions, but do we have actually standards standard operating procedure, saying this will be done by so-and-so, this is how it will be delivered, and the beyond trials for adaptation and use by providers. We need to start to think about, when we say we are doing treatment or testing and counseling in a HIV program, we know the algorithm, we know what providers need to be trained, or even if we are doing a prevention intervention, we are saying it is prevention with positives. We know who needs to be trained, where they track whoever is HIV positive, the curriculum that they give them, the number of sessions that the minimum is supposed to be attended. If we say prevention interventions, do we have that are commonly agreed on? And we need to start developing that from the data we have, from the evidence we have. And then we also have targets by geography. So the question around what would coverage of IPV prevention look like in our countries? And so finally, I think we need some paradigm shifts. So I'm going to suggest that the paradigm shifts need to, one, start in research. We need to move from international to localized research. Localized in terms of modeling, in terms of identifying surveillance points and surveillance data needs. We need to look at mentorship and long-term training. When I look back at myself, it is the training of a lot of people, some of them in this room, that has made me a researcher that I am. And it didn't happen in one day. It was over a long period of time, to writing, to supporting thinking, to being part of reviews, because that is what it takes. And we have to make that more formal and more structured. Excuse me. And we need local researcher-led incident studies, because first we have to define what is IPV, but incidents and social science. Because if we don't have that, highly unlikely we'll be able to do all the costing units, and cost-effectiveness work that we are talking about. Second paradigm is that from research to policy and programs, let's start to think about government owning research agendas. And there are a lot of research bodies that nobody goes to support that are government research bodies. So we have a lot of support in interventions, or a lot of support in research for specific things, for HIV, for reproductive health. How about the research institutes of the country? How about the research or the research committees of the regional bodies? Who is supporting those? Because if the agendas are not taken by government, what will happen is that then they become localized agendas for organizations, for interested networks, but they really never make it beyond that to becoming national agendas. Then investment in implementation science, I think I've already belabored the point, and then targeted packages. I think we also have to think about IPV beyond healthcare. We have to think beyond healthcare. As long as we are thinking healthcare, then let's structure a response for health response, which is not prevention. Because the reality is the health sector will only go for prevention insofar as it is within the mandate of the health sector. Primary prevention, which includes schools, which includes communities, which is not going to happen, because that's not the job of the sector. There is a sector that is responsible for that. It will not happen. It will only then focus itself on the response and prevention insofar as it has a direct impact on the response. So I think it's really important to start to think about that. And then from health to everybody's business. Political leadership, I keep saying social movements because I'm learning the power of social movements, and legal and structural reforms. So thinking about our future, I think the burden of violence, first is the post-2015 agenda and violence and the burden of violence. When you look at that data, in Kenya, priority non-communicable diseases, violence has been placed not with injuries, but with that green line. We will look at our strategic plan. But often it's not violence thinking about intimate partner violence. It's all other forms of violence out there. Stabbing, homicide, all of those are things. Who said that this is not an opportunity that we can turn by providing the data, the information, and starting? Because the documents, the policy guidance says violence. It didn't say which type of violence. So I think those are options, and I think it is the same is happening with the East African community. I think Dr. Dondi is here. And I think there's the same that's also happening with IGAD around the question of violence. But we are looking at violence in every other way. Can we use that as a leverage? The second one is the health sector response and how we can scale it up. HIV prevention has gained traction. How can we layer the work that we are doing on HIV prevention? And then the Global Fund Gender Strategy for research and programming resources. My only fear when it comes to it, we'll not have the data that we need. And I'm thinking about Kenya has to deliver the concept note. I think we also have a few other concept notes in the region. We have some that are not doing concept notes, but are doing their proposals, some diseases like malaria. And the truth is, there's a gender strategy, there's resources for it, we'll not have the data that we need to be able to pull down sufficient, well, not sufficient, but really good amounts of money to be able to address these issues. And all we need to do is have the data. So back again to my political questions, back again to my technical questions, because when it comes to writing that proposal, that is the information that will be needed. So thank you very much.
I'm very mindful of the time, and I want to thank our speaker very much for setting the stage for Ways Forward. She gave us many important strategies for moving forward that built on what we've heard the last day and a half. So what we're going to do, if it's all right with her, is let her off the hook on questions, and we can have people engage you perhaps afterwards. And then I'd like to bring the final panel forward, and we will work on the ways forward, getting input from the audience as well as from our final panel. So we thank you again very much. You really set the stage for all of these ways forward, and especially knowing that you weren't feeling very well. It was a fabulous presentation, so can we thank her again?